start with Nicole. She's got the Department Educational today on outpatient specialty clinics.
All right, so I'm Nicole Olinger. I manage the outpatient departments. I've been in this role for about 1.5 years, coming up on 1.5 years. So we'll get started here. The outpatient department includes a specialty clinic, surgical clinic, infusion center, and cardiac rehab. So just an overview of all 4 departments. We have 20 specialties that come out, and that consists of about 40 different specialty providers. I just took numbers from last year. We had approximately 13,000 visits, and then as far as employees, we have 10 full-time staff members, 4 part-time staff members, and then 6 on-call or as-needed staff members down there. So here's our outpatient surgical clinic staff from left to right. Sam's over there. Sam is the general surgery LPN. Stacy is in the middle there with the curly hair. She is our RN navigator for orthopedics. Amber's kind of in the back there. She is Dr. Kelly Anderson's nurse. And then Steph over on the side there, she just obtained her CMA, and so she can do a few more duties down there, and she kind of helps with all of those clinics. Amanda Irwin is not pictured there. She'll be starting on the 15th with us, and she will also help in orthopedics, but she'll kind of float between specialty and surgical. So there's a list of all the surgical clinic providers we have. I think the last time that you guys had a outpatient department presentation was 2018. So I tried to put the new providers in that red color. So Dr. Leroy Hodges is the new general surgeon. He'll onboard full-time September 6th. And then Dr. Kelly Anderson was new in 2020, I believe. Dr. Bays still does our total joints for hips and knees. And then we have added Dr. Blake Bodendorfer. He's our sports medicine and shoulder guy. He kind of took over for Dr. LaRose when he quit coming out. Dr. Shu's the hand and wrist specialist we have. Rick Hart's our spine specialist. And then the 2 PAs that come out as well. So right now we are up to about 10 days per month for coverage. That kind of just depends on the day, if there's a 5th Monday, all of that sort of thing. They see about 170 patients each month, just depending on vacations and that sort of thing. And then we do have a comprehensive individualized joint camp now. We used to do it all together where like 5 or 6 people would come in, but we just try to do it individualized now because Dr. Bays has some new protocols, so that works really well for us. Dr. Kelly Anderson is our OBGYN provider. She sees about 135 patients a month, and that continues to grow. She does provide surgical services twice a month, but I won't go into that. That's more of Kelly's role there. She does primary health care for women, manages pregnant women, and then she also does genetic testing. So not only if you're pregnant, but also just for well woman visits if you wanted genetic testing. Sorry about the grainy photo. That's Dr. Hodges. He'll be our new general surgeon. I think you all know that. And he will onboard September 6th and give us 4.5 days of coverage. And so volumes are to be determined at this point. Then we'll move on to outpatient specialty clinic. The 3 on the right are our access specialists, Jeannie, Riley, and Jill. And then I have Tanya and Tammy over on, I guess it'd be our upper left. They're our main cardiology staff, and then down below is Cassie, Brooke, and Steph, who floats back and forth between surgical and specialty clinic. So that's kind of how it's broken down in specialty clinic. Tammy is our cardiology coordinator. Cassie Johnson's our LPN coordinator, so she kind of has the entirety of the specialty clinics that come out. She answers a lot of those questions for any of the staff members and works a lot of the clinics. Michelle Weiss is our RN navigator, so she intercepts all the external orders that are coming in, and she pushes out all the external orders from our providers that are going out. So she's kind of a care coordinator for our patients here at Myrtue. And then there's a list of our staff nurses. We have a great group. Some of them they're pretty new to outpatient, but they're not new to the facility. So. And then here's a list of just all the specialty clinic providers that we have and the different specialties. Again, I tried to put the newer ones in that red color. So neurology is new in the last 6 months. Dr. Bays comes out, and then Andrea Anderson also comes out with Dr. Hussein now for oncology. Vascular, Dr. Talukdar comes out. Endocrine, we do telehealth with Dr. Andakuri once a month. Nephrology, Dr. Nazmal comes out once a month. We're trying to increase that to twice a month by providing a telehealth clinic with him. Epilepsy, Dr. Swaminathan comes out now, and that will actually be changing in October. Dr. Swaminathan will be leaving, and we'll be getting a new provider. And then thoracic oncology with Dr. Berkheim, and then we also started the allergy injection clinic since the last time you guys had a presentation. As far as cardiology, we're very lucky. We have cardiologists out here every day of the month except for 2 right now. Dr. Albelushi is new in 2021. He started coming out, and he's with Nebraska Medicine. And then I didn't put up there, but Dr. Ayub has started coming out every other month for Jenny Ed. So he does like the devices, the pacemakers and all that, which is good to have him come out here. As of right now, what we're working on is onboarding a rheumatologist, hopefully in October of this year. Dr. Wilde will be coming with Premier Specialty Network. So in the process of onboarding her, and then like we talked about, adding a day of nephrology and an additional day of oncology with the group that we have now. Moving on to cardiac rehab, again, Tammy Blatt is our cardiology coordinator. We were able to hire Alma Gokenauer, she's the one on the right there, as our full-time cardiac rehab nurse, and then our staff nurses are below. They fill in for vacations and that sort of thing. So Alma came to us from CHI Valley, and she did cardiac and pulmonary rehab there for 5 years. So we were lucky to get her. As far as cardiac rehab, at Myrtue we do phase 2 cardiac rehab, so that's after the patients are out of the hospital, and that includes 36 sessions, and they come 3 days a week. And then once they graduate from that, they can move on to phase 3 at the Wellness Center with the Live Well program. This last fiscal year, we saw 1,739 patients, which was an increase from the year before. I think the year before there was some COVID, that COVID just caused the numbers to be down a little bit. So, and then with the onboarding of Alma, we are beginning the steps to obtain certification through the American Association of Cardiovascular and Pulmonary Rehab for that department. And lastly, the infusion center. So Elizabeth Nolting is our new RN navigator for oncology and infusion center. She came to us from a urology center, but she has been chemo certified in the past. So she'll be attempting to obtain that again. You just have to have so many hours of chemotherapy. And then Michelle Weiss again is our RN navigator, but she fills in for Elizabeth, and they kind of do each other's positions. And then they're pictured with our chemo bell, which we purchased last year for our chemo patients when they graduate from chemo. Last year we saw 1,115 patients, which was up from 723. We did add new services, like we do port and pick line lab draws now rather than have the patients go to lab and have nursing staff do that. We added albumin infusions. We do blood and blood products now down there. And then we just added Depo-Provera injections for Dr. Anderson. There's some survey responses up there. In July of 22, we were almost at 100%. We had no dissatisfied responses, but we had one just satisfied, not very satisfied. So I think the big thing with our department down there, our staff says it, and at every meeting we have, is teamwork is key. Everybody kind of floats to different areas, and a lot of people can fill in for each other, so it just makes things flow pretty well. That's all I got. I talked kind of fast, sorry.
Are there any questions for Nicole?
We always hear good things about you guys.
Oh, good.
Yeah.
Good.
Yeah.
The cardiac rehab, who runs the Live Well program?
Alberti, we send over to Jackie over there, and then she starts that. So they get a discount on their membership over there, and obviously it depends on where they fall as far as their age, but they do get a good discount, and they start with her, and then they kind of continue on their own. So they're not monitored over there like they are.
That's what I was going to say, is there monitoring, and does any of that stuff go into their MyChart or?
No, there's none of that. Obviously, they're not hooked up to any electrodes or anything. Phase 2, they're monitored the whole time when they're here, but once they go over there, it's more of like a lifestyle change for them. Like, it's trying to get them to continue exercise on their own rather than having somebody tell them to do so.
Connection and continuum of care stuff there, so.
Yeah.
Very cool.
Good.
Thanks.
Yep. Thank you, guys.
Thanks, Nicole.
Thank you.
Okay, at this time, I'd like to call the meeting to order. First up is the approval of the minutes from June 28th. If I could get a motion on those.
I'll move the approval of minutes.
I'll second.
All in favor?
Aye.
Medical staff meeting summary. Karen.
Yes, medical staff met on August 9th. Basically had some Discussion from the Infection Prevention Committee, again looking at the masking. As everybody's aware, we're still masking in the hospital. We still continue to have inpatients, approximately on average 1 inpatient a day, not new patient, but here for a length of time, as well as having some employees who have had COVID. So we are continuing with the masking at this time. The committee decided there have not been any changes from recommendations from CDC, et cetera. So we are continuing. Monkeypox, I'm sure everybody's been hearing about that in the news. We do have some cases in Iowa, none in Shelby County that we were aware of. Basically gave the medical staff some information from the CDC as well as the Iowa State Hygienic Lab on everything from testing, vaccine, some of the medications that are out there, just so that they're aware if anything were to develop here in Shelby County. Nancy Gower, pharmacist, let the medical staff know of some shortages that we are currently having with medication. One of them is lidocaine with epi, that's a numbing medication, as well as a blood constrictor. So we do have that available, it's just in short supply, so Nancy is kind of allotting it out or guarding it very closely. Medical staff can have it and available, that she just wants to make sure that we're using the exact amount we need, not wasting anything. So just kind of monitoring that closely. Ativan or lorazepam is another one that's on short supply right now. This is a kind of a sedating medication. Again, we have it on hand. We have alternatives on hand. Nancy just wanted to make sure the medical staff was aware if they need it, that they need to contact her. And then there is a nationwide recall on citrate of mag. So Nancy gave them some information on what can be substituted for that medication. And let's see, we did give a high level, Jeff and I, update on the communication project. So we're switching over to the communication app with Tiger Connect. We've had a few initial calls with the company as far as bringing that in, and some kickoff will be next week. And then we'll start providing education to the medical staff, and then replacing over our new cell phones are in-house and being programmed by the IT department. And then those will be distributed with all of the apps and everything on them that we need. So projects moving forward and going forward with that. And then Mary Peterson did let the medical staff know that we have an upgrade for our Epic EHR coming up on October 21st through the 22nd. Not as many clinical changes with that. It's more registration and some of those pieces, the scheduling registration part of it. Big change for them. So not as much for the medical staff, but making sure they're aware of that coming in the future. That's all I have, unless anybody has any questions.
Okay, Laura, quality improvement report.
Behavioral health, they reviewed documentation compliance, which was at 100%, and as well as satisfaction survey, which was at 95%. Cardiac rehab monitored goals that are assessed at discharge, and then the exercise plan, which was 88%. Diabetic education evaluated all the referrals that they have coming in and the hemoglobin A1C levels after education. So they track those levels pre-education and then post-education, which is a great monitor. Dietary, check the timeliness of their nutritional assessments, adequacy of nutritional support, and food temperatures on over 450 meals. The emergency department monitors the care of heart attack patients coming in. The national average for a patient having a heart attack that comes through the door of a hospital and transferred is 61 minutes, the time it takes for that to happen. Ours is 36 minutes, and that's the direction we want to be on that. We want that transfer to happen quickly. As well as transfer communication, which was 100% for them. That's just monitoring all the communication that gets sent with transfers. Home health and hospice reported on documentation for medications, hand hygiene, and patient satisfaction scores. Infection control reported that there was no hospital-acquired infections or employee blood exposures. Maintenance checked compliance with all the facilities, satellite clinics, inpatient, outpatient, all locations for all of the maintenance and safety requirements that they need. Rehab services has kind of been focusing on the fall risk assessment of all of their patients. Respiratory therapy is reported on patient satisfaction and to patient identification for everything that they do. Rural health clinic reported on the ACO measures. Specialty clinics reported on patients receiving that after visit summary, which was really good, and then hand hygiene compliance. Surgery evaluated compliance with surgical case and tissue review criteria, that every surgery that is scheduled is meeting that criteria, post-op blood clots and post-op sepsis. One new thing that they're doing down in surgery is kind of collaborating with infection prevention and testing services for bacteria on a monthly basis and adjusting any cleaning measures based on that. So it's kind of a blue light type thing, and they're testing surfaces routinely. So it's a good addition. That's all I have.
Okay. Any questions for Laura?
Those transfer rates are fabulous.
Yes.
They are.
Those are really good.
Yeah.
That's very good to hear.
There's a lot that goes on involved in that 36 minutes.
Well, I can't imagine getting them in and out in that time.
Yeah, you have to do at least 2 EKGs, a lot of medications, you have to contact the transferring facility, and, you know, have your squad there and ready, and that's one of the big things with having Medevac working so closely with us, that they get those people out of here so quickly.
That's great.
It's a lot that happens in 36
And we're
minutes.
consistently below that average. It's not just at one.
It's a great service work.
That is great. Great to hear. All right. Jim, you want to present the Personnel Committee report, please?
Sure. The Personnel Committee met this morning at 7. There were 2 initial appointments, 3 reappointments, and 2 voluntary withdrawals. I'll make a motion to approve those.
I'll second it.
All right, we have a motion and a second. All in favor?
Aye.
Opposed?
Aye.
All right, that brings us up to the CEO report. Barry?
Yeah, I just wanted to talk a little bit about some of the new practitioners that we brought on, and Nicole has already provided some information about Dr. Hodges, but just wanted to give you a little bit more information there. We did just sign a contract with Dr. Hodges, and he was a locum tenens or temporary surgeon for us starting in July, and came in July and really liked what he saw, and we heard a lot of really positive comments about him from patients and medical staff and other staff, and so we did move forward with Dr. Hodges. A little bit of information about him. Received his medical degree from the University of Illinois College of Medicine and completed his general surgery residency at the Mayo Clinic Graduate School of Medicine. Also served in the Army Medical Corps and was on active duty during Desert Storm. He has served many years as a general surgeon at small and large health systems, including the Mayo Clinic Health System, where he's the Department of Surgery Chair. Practiced in 52-bed and 97-bed hospitals in Georgia and Alabama. So he's going to bring a wealth of knowledge and diversity and experience to Myrtue, and we're really excited to have him on board. So I want to just give you a little bit more information on Dr. Hodges. Also, we did sign an agreement with Children's Square to lease Dr. Walker, who is a psychiatrist, and we'll have him 2 days a month to start with. So he will see child and adolescent, so under 21. Then he'll also serve as kind of provide supervision for our mid-levels that are in the behavioral health department. So that should start here sometime in September. Nicole also mentioned rheumatology and Dr. Wilde. We think we're pretty close to having that signed, an agreement signed with Premier Network Services is who she is working with. She's been based in Omaha for the last 20 years, and we think we'll get her started in October. She'd be 2 days a month as well to start with. Potentially could add more depending on the volume there. Other medical staff items I want to bring up, just planning session. I mentioned this to some of the board members. We are going to have a planning session in September with our medical staff. We did ask Terry to facilitate that, so he will be there, and if any of the medical staff or any of the board members want to be there, just let me know. You certainly can attend that. It will be at the Turkelson's, and I think it's a 7 a.m. to 10 a.m. Meeting on the 20th.
You can
Of
tell me
September.
it's 7 a.m. Mary.
Yeah, we're going to get you,
I'm not
get you
gonna
going
make it.
early. So, and that's going to be somewhat similar to a session that we had about 3.5 years ago. Part of that session focused on kind of our physician practice model. And we want to talk about that and rehash that again, and make some decisions on what we want to do moving forward over the next 5 to 10 years, what that will look like. So again, you're welcome to attend that if you would like to. Then the next item I have is the building on Morning View Drive, where our behavioral health department is currently located. We signed a lease agreement with TJC Rentals LLC. They own the building. Signed a lease that started back in November of 20. Included in that agreement was a purchase option that had a set price. That set price is $246,000. The current lease, the rent is $2,700 a month. So the total per year lease payment is $32,400. We think the purchase price is reasonable, and we do think that if we would need to sell it out into the future at some point, we could get our investment back out of it. I think having ownership of that building will give us the ability to make some alterations and make some improvements that we would like to make a lot more easily moving forward. As part of our master facility plan process a few years ago, 3 or 4 years ago, before COVID hit, we were looking at, in addition to the east side of the clinic, and the second floor would be our behavioral health department. That was what we were looking at back then. At that time, behavioral health was in the little building up here on the northwest side, corner of the hospital campus. I think that building had maybe not more than 2,500 square feet, something like that. We increased our square footage to over 5,600 with this new building. So, it is meeting our current needs, and we think it's a good building, and it's really doing what we want it to do from the standpoint of accommodating behavioral health services. So the request, what we're asking for today, is to approve to exercise the purchase option on the lease agreement of 1110 Morning View Drive building, and we would like to try to close sometime in September on that building. Any questions on that?
I think it makes sense, really.
I do too.
I mean, financially, just 40% of it is paid back in the first year, just in payments. I mean,
Yeah, we did
considering
talk about
taxes.
this at the Building and Grounds meeting, and had, I think, support for that approach.
I'll make a motion to approve that.
Okay, Jim's made a motion. Could we get a second, please?
I'll second that.
All in favor, say aye.
Aye.
Aye. Opposed, same sign. Motion carries.
Okay, I think most of the rest of this I'm going to have Jeff talk about the conceptual design and the construction manager at risk. So,
Yep,
Jeff.
I will. So first off, I don't know if you all know what a construction manager is or what they do, but they are a professional service that provide project owner, us, with effective management of a project's schedule, cost, quality, safety, scope, and function. So they oversee the entire process and help coordinate from design to the finished product. They act on our best interest and provide oversight on the project that they're associated with. So some of the things they do is they manage the planning, design, and construction from beginning to end. So they're involved very early into a project. They ultimately reduce the overall project cost because they have kind of the fingerprint on what the market is doing. They are continually, as design goes through, looking at availability of product, the costs, the timing, everything on there. So, for one example, we had in some interviews that construction manager was brought on early. They noticed that the price of steel was increasing quite a bit, and with this project, it was I think about a $10 million overall project. They said, hey, steel's going to skyrocket, the availability is not going to be there. They went to convince the project team we need to order now. Before the project had even started, they went and ordered it and estimated they saved that company over $1 million, and just in the timing of that purchase. They validate budgets throughout the whole process, so they continually are looking at the cost of materials, how we are performing. Also, construction manager at risk, they're responsible for finding and hiring the subcontractors. So they are ultimately acting as a general contractor over the whole project, but they are the ones that are responsible for the work that the subs do. They monitor the scheduling and the work that the subs do. They provide a better quality project at the end. They also negotiate some material discounts when applicable and review all the bills. So earlier this year, the legislature passed Senate File 183. The governor signed it, and it ultimately went into effect on July 1st. What this allowed was public entities to enter into a construction manager at risk relationship. Prior to that, we could go as an advisor, which construction manager just kind of gave you a little bit of guidance. At risk means that they are responsible for the cost. So the process that we went through for construction managers, we had to send out what's called an RFQ, a request for qualifications. It got posted to a statewide job board. Anybody could respond to it. And we had scoring criteria we had to evaluate, and all qualified responses were then offered an RFP, which during an RFP we could ask what is their pricing schedule, how do they charge, how do they monitor, and get more down into the detail of a project. We then held interviews. We had 4 entities respond to our RFQ, which all 4 subsequently were offered a response to the RFP. They're it's actually Murray Company, Beckenauer Construction, McGough Construction, and Graham Construction. Murray, McGough, and Graham all have Iowa offices. Graham is, for this project, was the Omaha office was going to be here. Beckenauer is out of Norfolk, Nebraska. So, as I said, the construction manager will act as a general contractor. They're responsible for cost overruns, scope changes, and if we completely change it, it's our responsibility. But any change orders are the construction manager's responsibility. They give what's called a guaranteed maximum price, a GMP. That is what they will work off of after all the design and everything is completed. So they're working towards that GMP. If the project comes in under price of that GMP, we get that money back.
Chuck,
Yeah.
I get what the legislature did for, public entities to do this. What do these construction managers at risk have to do to qualify? Is there some kind of certificate they're granted to be? Graham Construction in Norfolk, not an Iowa company.
Right, Beckenauer, yeah. We had a list of criteria that we went out, list all your qualifications. We asked for examples and just describe those projects that you worked with on the construction manager at risk. So they gave us specific examples there. We looked at the personnel that they would have as part of the project and their resumes. Somebody said, I just graduated school and they're going to be the project manager. Well, that doesn't bode very well. Most everybody had quite experienced staff.
So it's really the criteria of a hospital, school
Yep.
district, municipality, whatever.
Yes.
It's what they want, and okay.
Yep, and then the RFP builds on that. So then on those examples they provided, we ask additional questions about them to provide that. A few additional questions on the qualifications of the staff. and then the pricing and how they work through the pricing. We had some follow-up questions on pricing, and then had them in great detail explain how they charge and how they come up with the costs.
Thanks.
Yep. So Murray Company is the entity that was scored the best through all of our criteria and evaluation. That evaluation, because this is a USDA project, had to go down to the USDA to get their approval. They reviewed every response on the RFQ and the RFP, looked at all their pricings, and subsequently approved Murray Company as the construction manager that provided the best product or services. So from moving forward, Murray would assist in finishing the schematic design, which we are very close to finishing. We should have that within the next couple days. We've been working with the architect Altus, going through a number of projects, and this is the perfect time for the construction manager to get involved. They're already working on the first high-level budgetary number for our project. They'll be fully involved in the detailed development of the plans, which from our schematic diagrams, they'll take that and they'll start looking at how the electrical all has to run, the networking, the flooring, the walls. They'll look at everything. They'll get very detailed design. Next step would be the construction document development, which if we move forward beyond each of these steps, and at each one of these steps, we have the option to approve and go on to the next step with Murray, or say, thank you for your work so far, we're going to go another avenue. So there are several opportunities to separate if need be. But the construction documents, Murray then would take and create numerous bid documents based on each of the products that are needed, the electrical, the steel erection, the roofing, you name it. They would have the bid documents. They have to go through a very similar process that we did to hire the CM, to hire the subs, that they have to pre-qualify based on certain criteria that they put out, and then also offer those qualified bidders the opportunity to bid, and then take the best value, lowest price. So there's a lot of criteria that needs to happen, and then also USDA is involved in that process to ensure that it is competitively bid. They then, off of the construction documents, will provide the guaranteed maximum price, and that is what our overall cost would be at the max. They then, after that, would manage the complete construction process, and like I said, at the end of each of the stages, we have the option to terminate the agreement. Any questions so far? So I'll give you a sneak peek of what we've been looking at. At a high level, this is a schematic design kind of on the outside. Our existing ambulance garage. Right here, I don't know if you can see, there's a kind of a green dotted line. That is the existing north wall on the exterior. So we would be potentially building all this as new construction. Remodeling a little bit down on the south side. This is diagnostic imaging right here. And then here's a little, more detailed on how it would look inside. Sorry, you can't read a lot of the things. Entryway here, waiting, 2 different waiting areas, restrooms. We'd have a triage room so we can determine which way the patients would need to go. We have 4 exam rooms on this side, 2 procedure rooms here, 2 trauma rooms. The 2 center treatment room or exam rooms here would also have the capability of handling behavioral health. So they would have a garage door to come over and protect all of the equipment when we have a behavioral health patient there for a longer time. Offices, decontamination area down here, some storage, staff conference room, more storage, adding a sleep room for the diagnostic imaging weekend people so that they're closer to when they need to have a call and take care of some images or anything, they'd be a lot closer there. So this is schematic, it's still not finalized. Next week, we hope it will be closer to finalized, then we'll enter into moving forward with detailed design on this layout.
So the addition that you're doing, is it doubling pretty much the size of that?
Yes,
current unit?
roughly, yep. I think we're going from,
How far out in the road, how far out will that go then?
you can kind of see right here is the fence, the current fence. This is the edge of the
Still room?
helipad.
Still room for everything to get through there?
Yes, yep. We're still working on how entry might come into this. We're looking at a possibility of an entry off of 12th Street, still entry off of Garfield's, maybe 2 entries off of Garfield's based on deliveries and patient flow. Still trying to evaluate some of that. There was thought, the nuclear or MRI truck currently
That's what I
parked
worried
right here.
about, getting that in there.
There's a concept that they're looking at that we could move it up in this area. Concern is the slope of the area and how much leveling this trailer would have to do. But then there's another diagram leaving the MRI here, adding a second roadway through to allow traffic to go through, possibly moving the helipad over slightly so that we can get the traffic through that east side.
Would you redo the parking lot, the patient parking lot also?
Yep. Yep, turning that entrance, we'd widen the entrance so we can get 2 vehicles in, and it'd be perpendicular parking instead of angled parking.
And you would add some number of parking spaces. There was going to be more parking in one of these.
In one of the options, yes.
Yes.
Yep. And an option coming in, and we're looking at adding a canopy going out over for vehicle drive up to be underneath. If that's the scenario, we have a potential cul-de-sac, call it a cul-de-sac here, rotary, I guess is a better term, a rotary, to come around, drive around, drop patients off. We would lose any parking potentially in here because that would be used for a lane to bring patients in.
It's very well needed.
It's a lot of work been going into this. Karen and Jenny been working a lot with staff, Christy, myself, Barry, Drew, weekly meetings, lots of work outside of those meetings to get things kind of squared away.
On the construction manager, there's 2 different phases to that project. The first phase is pre-construction, and so they're starting to work with us now. The cost on that is $15,000, and then when we get to the end of design development, that's when they'll set the guaranteed maximum price. And that's when we'll come back to the board for full approval to move forward with them and, the whole project. So that's when we would get approval to move forward with Murray on really the majority of their engagement with us. But right now, it's just the pre-construction costs.
Have there been other hospitals or public entities that have used this Murray before?
Murray, yes, they've done a lot of work here in Iowa. Their offices are St. Louis, Des Moines. They go into one office into Illinois. I don't remember if they have an office in Minnesota, but they're central Midwest. Is it Clarion or Sheraton currently? Oh, Shenandoah. They're working on a project in southern Iowa right now. The actual superintendent and project manager that are working that project will be working ours.
Have you talked to that hospital or whatever entity that is?
Yes, we have. They speak very highly of Murray. I also talked to a 25-bed critical access hospital as a reference in Illinois, and they're the ones that gave me the example of saving them $1 million potentially on their entire project. Any other questions?
So, motion to,
Do we need approval on this?
That's what
No.
you're.
No.
thank you. That was my question.
This time.
Thanks.
All right,
Thanks
thank you.
for the update on that, that's good.
Barry, do you have anything else?
No.
Okay, all right. Christie?
Okay, well, these are draft financial reports. We will have our audit starting the 6th of September. The auditors will be out, but just to kind of give you an idea as to where we are looking for ending the fiscal year. So in June of 2022, we continued with having high outpatient visits of 5,800, 435 ER visits, 135 surgical procedures, 3,544 RHC clinic visits. Our average daily census was down a little bit at 8.4. We had 7 births. At 3.6 million in revenues, net revenues, and roughly 4.2 million in operating expenses, which results in a loss, which is $500,000. A lot of adjustments in there that are year end. You know, we always open our year end much farther so that we can absolutely make sure that we accumulate all of our payables and other adjustments that are just done at year end. So that is really the reasoning behind the loss there. Now, we already know what our IPERS adjustment is. The auditors got that to us early. You know, as we've dealt with for years now, that IPERS adjustment is really saying, you know, booking the liabilities that we have based on our current contributions to IPERS and what they anticipate we will pay out for IPERS. So a lot of that has to do with the fluctuations in the stock market and in their investments. It's a year behind, so that adjustment is based on really what was the market values at June 30th of 2021, which we all know were really good. So we are seeing an increase of a positive adjustment this year is $2.5 million. When I get to the 4-year, you can see this is the first year in 4 years that we've had any kind of a positive adjustment. We know that next year, when the markets are down, June 30th of 2022, we're going to get a pretty significant negative adjustment next year. So it's just a paper entry. It's not that IPERS is ever going to come back and say, you got to pay us this money or we owe you this money. It's an audit adjustment that's required by generally accepted accounting standards. Then we go down to our net non-operating. Again, you can see that is a negative 157,000 this month, and that is due to fluctuations in the market, again, with our investments. So for June, we had almost 1.9 million in net income with that IPERS adjustment, and last year it was almost $3 million. If we look at year-to-date, then where we see, year-to-date for June, you can see we've seen some increases in our services for the most part. Outpatient is up 4%. Our ER visits are up 20%, almost 21%. Surgical procedures, it's 1.4% down. That is a total of 21 surgeries. Our clinic visits at the RHC are up 10%. Our average daily census is up 4.4% there. And our births are up 62. So we have had 81 births this year, 62%, excuse me. We had 81 births this year compared to 50 last year. So seen a pretty significant increase in that. Our revenues are up 8.9% and our expenses are up 8.8%. Gives us a little bit of a loss there of $289,000 for the year. Again, this is draft. So our IPERS adjustments, 2.5 million. Year to date then, our other operating, we did get a little bit of additional federal funding this year due to COVID. So that is why that is higher than in normal years, but it is lower. Last year, of course, in 2021 is when we got the majority of those additional federal funds. So we're at about 5 million net income from all sources with that IPERS adjustment. Last year was 8.2 million. Now you can flip it if you
Good.
can. Okay, so this is the 4-year comparison that I've been doing just to kind of see where we were and what COVID has done to us. So you can see there our outpatient visits has continued to go up. So we're at 70,000 for year, 70,390 outpatient visits. So that has to do with behavioral health, all of our outpatient specialty clinics, people that come in just for labs or come in for physical therapy, radiology, it's all those outpatient services that we do. And that's a pretty substantial increase there. Our ER visits, as you can see, were a little bit higher than we were in 2019. So you can see we dipped down there in 20 and 21, and now we're back up. Surgical procedures have, saw that where we were closed down in 20 for COVID, have recouped and a little bit and stayed pretty consistent there. RHC clinic visits, we started in 19 at 45,355, and this year we're ending at 45,142. So we have recovered pretty good from that. As you can see, our average daily census in 19 was 11.08 patients per day. Pretty consistent, closer to the 9.5 patients per day to 10 patients a day, basically. We're seeing dips in observation. We have recognized for years that we see dips in swing bed. They go more to nursing homes than here. As you can see, our births have been at the 57, then we went to 68, 50, and now at 81. And you can see our revenues just continue to go up there, pretty consistent between 19 and 20. Expenses have continued to go up also. Supplies, staff, everything is higher than it has been. And we've added a lot of professional services that we pay for under contract now. As you can see there, that's that IPERS adjustment. It was 300,000 negative in 19, went to 803, went to 615, all negative, and then this year with the market, we see that increase. And you can see there our other net operating, it's generally around the 1.2, then we went up to 3 million with some COVID money in 2020, a significant increase of 9 million for 9 million in 21 with a lot of additional COVID funding, and this year we're at 2.7. So looking to be again around that $5 million mark at the end of when we get our audit completed. Don't foresee any adjustments. They don't do the cost report until they go through the audit, and that kind of tells us, we try and estimate what do we possibly owe Medicare back, or what do they owe us, and that cost report is what really determines that. So that's the only adjustment that I foresee happening with our audit.
Do you think that's significant?
It shouldn't be. I mean, we've never had an issue with, we didn't have an issue with them last year. We didn't, I mean, it's kind of a combination of, this is what the report shows, but you know, this is what we foresee happening in the future too. And so we get a lot of input into that.
I think if there's anything that gives you perspective on the last 3-4 years, is looking at a condensed financial statement from a medical center. So thank you again for continuing to put that together, Christy, to look back to 2019.
And just on the balance sheet, I mean, we don't need approval for this because it is all draft, but the balance sheet continues to look strong. Our AR is down a little bit from what it was in June 30th of last year, and our allowable for uncollectible accounts is down, and that would indicate that our receivables are much more current. So that's a great thing. We did see quite a few people during this time when they weren't going out and doing other things and using their funds to pay medical bills. So that was a positive in the situation that we've been through. But is there any questions on any of this?
Payrolling claims are in your packet. We need approval for both the June and July. Make that in one motion.
I'll move to approve the June and July payroll.
Thanks, Sally. Grab a second, please.
I'll second it.
Thanks, Leona. We have a motion and a second. All in favor say aye.
Aye.
Opposed, same sign. Motion carries. All right, at this time, looks like we need a motion to go into closed session.
I'll move we enter closed session.
I'll second it.
Okay, we need a roll call vote on that. Ruth, if you could do that for me, please.
Mike?
Yeah.
Terry?
Aye.
Kelly? Janine?
Aye.
Leona?
Aye.
Tom?
Aye.
And Jim?
Aye.
All right.